My name is Ron Montoya, and I'm chair of the board of the Latino Community Foundation of Colorado. It gives me great pleasure to welcome you to the Foundation's first annual forum, Telling Our Stories. Today's forum complements our new vision of playing a greater role in the community by convening people and discussing critical issues that are pertinent to Latinos and that allow members of our community to reach their full potential, no matter what stage they are in life. Today's event is a huge undertaking and could not have been possible without the vision of our board to be courageous and forward-thinking. So I want to thank them for setting a new and exciting course for the foundation. I also want to thank our administrative and project staff, as well as volunteers, for all their hard work and making today a success, and for their tireless work throughout the year. If the staff is here, would you please raise your hands, and thank you very much for all your work. Thank you, thank you. And a huge thanks to Rose Community Foundation. Rose Community Foundation played an instrumental role in creating the Latino Community Foundation, and their support and leadership over the years has allowed us to grow, leverage opportunities, and position the Latino Community Foundation of Colorado as a visionary leader. We would not be here today without your support, Rose. Thank you very much. We all know that this work cannot be done without the support of our sponsors. Therefore, I want to thank our gold sponsors, the Denver Art Museum, this beautiful facility. Thank you. Miller Coors for their continued support of the Latino community. Our silver sponsor, AARP, and our bronze sponsors, the Colorado Health Foundation, the Colorado Housing and Finance Authority, the Colorado Trust, the Denver Regional Council on Governments, Dr. Cog, Latinas Represent Colorado, Pasco, and Wells Fargo. Thank you, and thank you very much for your support and your sponsorship. Also to welcome you this morning is Andrea Fulton, who is the Deputy Director and Chief Marketing Officer of the Denver Art Museum. We're so grateful for their sponsorship and want to thank her and her team, Dennis Smith and Mike Casper, for going the extra mile and making today's forum perfect. Please, welcome.
Thank you. Thank you so much. I'll be really brief, but I just want to say welcome to the Denver Art Museum. Thanks for being here today. Lots of friendly faces in the audience. Great to see everyone, and we're just so honored to be a part of today's annual forum. And I just want to say thank you so much to Carlos and to his whole team for allowing us to partner with them. He's been a fantastic supporter of the museum, and we're just so grateful to be aligned with an organization that's doing great things to recognize and celebrate the invaluable contributions of the Latino community in our state. 2 seconds about the Denver Art Museum. If you're not familiar with us, we're about 120 years old, and we're one of the largest museums between Chicago and the West Coast. We have encyclopedic collections, but a real strength in the art of the Americas, which includes Spanish colonial, pre-Columbian art, American Indian art, and Western American art. So if you get a chance today to peek around the galleries, please feel free. We'd love to have you check out some art while you're here. While we have great collections, we're also really well known for our engagement of youth audiences in the museum, and we were recently named one of the top 10 family-friendly museums in the country by USA Today, which was a great honor for us. Our family activities are all offered in English and Spanish, and we continue to strive to really connect people to their own creativity by engaging with artists, by trying their own hand at creative processes, and also seeing the creativity in everyday life. And we want to make it fun. We hope that it's fun here. So this is not meant to be an art museum that you have to be very quiet and only look. You can do things in this museum, which we're very proud of. And while engaging families has been a hallmark of ours for the last several decades, today's topic is of great interest to us. We're really hoping to make this decade one that we look back on and say that we really move the needle in terms of engaging the broadest spectrum of the community, and that includes aging populations and Latinos. It's a huge focus for us right now. So we look forward to learning today from the speakers, from all of you as participants, and being a part of this conversation. I would be remiss if I didn't give a quick program plug. Tickets are on sale for our big world-exclusive Beacon exhibition right now, which is brilliant Cartier in the 20th century, and that opens in November. And the family and the adult audio guide are available in Spanish for that show as well. So have a great day today. Thank you again for letting us be here, and we look forward to a strong partnership with the Foundation in the future.
The Latino Community Foundation of Colorado was founded 7 years ago. During this time, it has invested over $1 million on the Latino age wave and over $1.2 million with over 70 nonprofits, Latino nonprofits, who are helping to address issues around children, youth, immigration, health, policy, economic empowerment, and culture, so that Latinos have opportunities to thrive. We've helped communities all across Colorado, from Alamosa to Greeley to Denver to Montrose and many communities in between. For those of you who have supported us, your investments in the LCFC have been hard at work, making Colorado a great place for Latinos. Thank you so much for your support. As a trustee with Rose, I was presented an opportunity by Sheila Bagdanowitz and Elsa Olguin, and they talked about what it meant about philanthropy and what philanthropy could mean to the Latino community. I was just amazed at their support. And I knew that I was going to need personal resources and personal resources of other people to start this program. But I knew if the Rose Community Foundation was behind this, that it would be successful. So I believe that we joined arms and we began this journey 7 years ago. Last year, the board revised its mission and developed a new vision for the foundation, which we started to carry out earlier this year. That vision is to bring together the human and financial capital of our people to build healthy communities where Latino babies, children, youth, adults, and our abuelitos can come together and live prosperous lives. To carry out this vision, we created 3 areas of focus. First, to be a thought leader, to harness the community's human capital to educate, share, and disseminate knowledge to influence policy and decision-making on critical issues to the Hispanic community. Second, community impact. Invest human and financial resources with local, statewide, and national partners who are committed to supporting innovative and relevant programs that help people reach their full potential. Third, philanthropy. To build a philanthropic community who is invested and engaged in the betterment of the Latino community. I am enthusiastic about our new direction and excited to present to you the Foundation's Executive Director, Carlos Martinez. Many of you know him, and those that don't, you need to meet him. Carlos brings to the Foundation 25 years of nonprofit experience. From running organizations, working with foundations, leading small to large-scale local, state, and national initiatives, a professor in policy work. Originally from California, Carlos has been in Colorado over 6 years and has made his mark here. Since January, he's been hard at work developing bold new strategies for the foundation, creating new partnerships, and engaging our community and to become philanthropists. He has launched 2 new initiatives. He's expanded our staff, raised over $1 million for operations, grant making and endowment, and creating a fresh new online and social media presence. He is recruiting new young leaders and is developing fun, stimulating, and thought-provoking opportunities for you and others to engage and to be connected and to be part of the larger community. I've had the pleasure of working with Carlos as a member of our board of directors and now as our executive director. I am just so proud of him because he's such a dynamic, energetic, and committed leader, and he has become my friend. So I'm very, very proud to introduce you to Carlos Martinez, and he'd like to share the future of the Latino Community Foundation with you.
Thank you, Ron. Thank you. Well, thank you everyone for being here today, this morning. I just got to get my notes here, and I may be changing glasses also, so my vision's not what it used to be. But thank you for coming and for spending your day with us today. The foundation is going through major changes to make sure, as Ron was saying, that we create healthy communities throughout Colorado. As Ron gave you a brief explanation of our new vision and how we're going to be able to move forward. You know, the other day I was talking to my nephew. I better get a clicker over here. And my nephew was saying to me, so Theo, what do you really do at the foundation? You know, what's your work about? I said, well, you know, we try and, you know, and build communities and so forth. And he really quite didn't understand it. But he loves Jenga. So I said, you know what? Let's look at our community like a Jenga tower. I said, so with the foundation where I work as, so if we look at the tower and that's a community, the different pieces are people, our community assets, such as a community center, a health clinic, different parts of our community. I said, and so just think about that. I said, so our role then is to make sure that there's always a strong foundation in the community. I said, because what happens in communities is sometimes, you know, people move out, the pieces are no longer there. Sometimes you have new pieces coming in. And the thing with our foundation is making sure that there's always a foundation in Latino communities so that there is an anchor, there's an identity of a community. That foundation is very key. We chose the topic of telling our story because I think telling your stories is so key in communities. It allows us to have a true identity of who our community is. And many times we don't share our stories. But the stories are so valuable because they help define who we are. And it helps to build that strength and the power that we need in our communities. So that's one of the things that we do. I told them the second thing is we need to invest. And I found this little cartoon where, you know, they're playing Jenga and it's students at the top and the little pieces at the bottom are maintenance, security, field trips. And the lady's saying, so who's the winner if this topples over before we finish making cuts? The gentleman says, no one. And the thing is that we have to constantly invest in our communities. It's not a one-time thing. It's not this year we'll do it. We have to constantly invest in our communities to make sure that there's always a strong foundation and that they grow. And then the last one, I told them, I said, you know, the thing also is that we need to engage. And you'll notice with this Jenga, it's different colors and the pieces are different. And the pieces are different because not everybody is the same. And I love this one because it's colorful. It represents the diversity of our communities. And the pieces are different because not all the pieces are the same. So many times we want our communities to look the same. And the thing is, what we really need to do is tap into the assets, which are the pieces, and the pieces are always different. And we need to figure out how do we create new communities with this changing identity. When I grew up, a lot of it, I was brought up and it was kind of like, you're bicultural. Well, what did that mean? That bicultural piece was, okay, you take a little bit of this, like my Mexican heritage, and the American heritage, and you put it together. Well, times have changed, And people are not like that anymore. I was reading this wonderful article or report that was put out by Latin Works. They're from Austin, Texas. And the report is called Identity Plus. And they talk about how a lot of younger Latinos, okay, no longer fit that bicultural piece that so many of us probably grew up with. For, back then it was you were bicultural, and part of the challenge for us was sometimes we didn't think we fit as an American, and we didn't think we fit as, if you're Mexican, for me, a Mexican. And I was always straddling, trying to do both. But I never really felt I fit in. So there's different pieces that you take from it. However, with younger Latinos now, they're kind of the different, especially as millennials. They say, I'm American 100%, and I'm Latino 100%. They're not going between and trying to figure out which of the two. And one of the things that's fascinating also with this is transculturation, is when Latinos, I knew I was going to mess up on that one, but they talk about it. It's so fascinating because they talk about it and they say, well, with a lot of younger Latinos, what's happening now is they're figuring out their new identity and who they are, not based upon what they were born into, but their experiences. They're coming more global citizens in our communities. Back when I was growing up, you never met a Latino who was also a Buddhist and did yoga. You see plenty of them now. My brother is a biker, with tattoos, and he does yoga. And so things are different now. And so the thing is, with our communities, and this is why I think it's for me, it's the most fascinating piece of my job, is how do we help communities make sure they engage everyone in there? Because everyone brings something. Everyone has talents. And it's be just great to see how it is that we build these communities, but still find a common ground where we have orgullo, where we have pride of who we are as a community. For me, growing up, was very challenging. I chose this photo. Of course, this is not me. And it wasn't me when I was a kid. But, this young gentleman here, you can tell he's just thinking about life, okay? And my journey in life, I had a lot of those moments throughout my life. And unfortunately, when I was growing up, there wasn't really anyone to go ahead and guide me and to tell me, this is what you're going to go through, this is what's going to happen. We were immigrants. My parents didn't know how to speak English. I didn't know how to speak English when I went to school. They were trying to figure out this new culture. One of my biggest, experiences is when I first went to school, to kindergarten, because I didn't know the language. And unfortunately, back then, if you didn't know the language, you just weren't considered smart. So they put you in another group, and you're just like trying to figure out, well, how is this defining me? And so it's interesting how you're defined. So that was really instrumental for me in my life growing up, how that was. And then the fact that where I grew up, we were one of the very, very few Latinos in our community, and there were very few whites because most of them were Japanese. So I grew up in a Japanese community and trying to understand, just like they were growing, where do we fit in within all this? The second experience for me that really was, a major challenge, that was a defining moment but didn't know how to process that, was I was 12 years old, and I realized that my attraction was to men and not to women. And I had no idea how to process that. I couldn't talk to my parents about that. I probably for 5 years, almost every day, went to sleep crying because I didn't know who I was. And I didn't know that there was a community that would support me for that. The next one was when I went to college. Wasn't sure what to expect when I went to college, and because it was so different. College had opened so many much more thinking for me of who I am, who I was, reading stuff, getting to know people. It just opened a whole new horizon. But how was that now going to fit into my identity back at home and with my family, my extended family, and figuring that out? And it's sad to say that through this process, there were very few people who I could go to who could go ahead and guide me. I didn't hear stories from anybody else that were similar to mine. That's why telling your story is so critical in your community, because you just never know who you're going to impact in your life. So as we do our work at the Latino Community Foundation, it's about taking these bigger concepts of identity, of who we are, and our communities are becoming so much more diverse. What is it, about 65% of Latinos are from Mexican origin, 35% are from all over. I mean, you know, we listen to salsa, we listen to everything now. It's just coming, it's a different appreciation. And so how do we take that and make sure that we bring it into our work at the foundation, and make sure that as we invest in communities, as we invest in people, as we invest in leadership, that people are making sure that there's always room at the table for everyone, and that no one is excluded throughout that process. So earlier this year, you know, talking about all this identity and community and so forth, it's like, okay, so how are we going to do our work at the community, at the foundation? And I'm glad to say that our board has been incredible. Our board has been just wonderful to be able to go and have really good discussions about how we see our community, how we develop programs, and how is it that we do our work to have a larger impact. Ron talked about those three areas: community impact, thought leadership, and philanthropy. With the community impact, that really is focused around our grant making and our special initiatives. I am pleased to say to you that next week, we'll be releasing our new RFP. So we will have an RFP that will come out, and we're hoping to give out between about $150,000 to $175,000, which is maybe not a lot, but for us, it's a lot. And we're going to be a little bit more focused on how we make those investments. We're going to be looking at health. We're going to be looking at education, civic engagement, art and culture, and work/career development. Those are the areas that we're going to be looking in. Then we have some special initiatives. Today, a lot of our forum today is going to be focused around our Latino Age Wave initiative, which completes 3 years. And we've done a lot of work and want to continue moving forward. So today you will hear a lot about Latino elders, the Latino silver tsunami that's hitting, and how it is that we're going to go ahead and make sure that our abuelitos, that our parents, have the services that they need so that they can age in their home with their family and in their community. We launched another program earlier, a couple months ago, which is called our Summer Melt Initiative. We partnered with Hispanics in Philanthropy. We are funding 5 organizations in the Denver metro area to address this phenomenon called Summer Melt. And that's when youth who graduate from high school don't make it to their first day of class in September at college. So it's kids who graduate, kids who get accepted to college, but never make it to their first day of school in September. And in some communities here in Colorado, that's as high as 70% of Latinos who don't successfully transition during the summer. So if that goes well, and it's like I said, right now it's going to be a pilot phase, we hope to then launch it statewide. Our next initiative that we launched earlier, and actually today, later on today, is going to be the official launch, is our program called Latinas Represent Colorado. It's part of a national initiative, a national movement to try to build a pipeline for Latinas who want to go into public office and be able to support them. It's not about creating another leadership program. It's about doing a lot of one-on-one individual mentoring that sometimes doesn't happen in some of these larger programs. And then connect these Latinas into the different types of programs so that they can excel and they can be our leaders and they can be making decisions for our community. So that's what we're doing right now within community impact. On the thought leadership piece, one of the things we wanted to do is have an annual forum, which is our first one today, to be able to bring people together to talk about issues, to be able to highlight what's going on. And then we're also going to be doing more white papers and reports as we move forward, and make sure that that information gets in the hands of policymakers, decision makers, so that when decisions are being made, the Latino voice is there. And the last part is philanthropy, is making sure that people understand what philanthropy is, but also the power that it has. When you're able to leverage resources from you, and you, and bring them together and then put them back out in the community in a strategic way, that has a lot more impact. Latinos are generous. We're very charitable, but we don't really engage in philanthropic opportunities. And many times because we've never been invited to participate. Not because we don't want to, but because we haven't been invited. And when we are invited, we're expected to do like what everybody else does. And that sometimes doesn't happen. That's not the way we want to go ahead and see philanthropy in our communities. So we want to make sure that we educate folks on philanthropy, we engage, and you don't have to give to the foundation, just make sure that you're giving back to your community. Make sure you're investing so that that ganja game doesn't topple over in your communities and that they're strong. So we have a lot going on. Oh, and just one other thing also, that we were able to get a grant from the Kellogg Foundation to help develop our own capacity. So when I first started at the beginning of the year, I was just basically a one person with a one-a-day assistant. We were able to hire another person as well. The other thing is that today is kind of like a soft launch of our new website. If you go, we have a website now. We have a whole social media. You'll see more about it throughout the day, because we really want to make sure that we're connecting with you, that we're connecting with your neighbor, that we're connecting with your family members, your children, because we all need to come together to build these healthy communities so that our communities can thrive. I mean, the next generation is the workforce of Colorado. We are growing, our numbers are growing, and we have to make sure that our community is going to prosper in this new Colorado and have those opportunities so that everyone can prosper. Thank you much for being out here today. Again, I just want to thank the Denver Art Museum for hosting us. They have been tremendous in working with us to make sure that this is a very successful event. As I was saying earlier today about identity and how important it is for us to tell our stories, because that creates a better identity, I invite you to visit the 4th floor that Andrea was talking about. That is a critical first step for us to really understand where we came from and understand how it is that we are just evolving and growing. So I invite you to visit the 4th floor while you're here today, or if not, come back. This is a great institution. For those of you who know me, you know that I love art a lot. And art is so important for me because it helps to define who I am as a person. And so it's wonderful when you're in a city that has great institutions like the Denver Art Museum, because it's not about just looking at a piece of artwork. It's about really creating identity for yourself and for your community. So again, thank you very much for coming today. I know that you will enjoy today's forum. And I guess with that, I will invite Therese Ellery, who is one of our foundation's advisors, and also with the Rose Community Foundation, Senior Program Officer in Aging.
Thank you, Carlos. Well, today we have the pleasure of having Dr. William Vega with us, and I am so excited to introduce him. He is the Provost Professor and Executive Director with the University of Southern California Edward R. Roybal Institute on Aging. That's really hard to say really fast 3 times. Bill holds USC appointments in social work, preventative medicine, psychiatry, and family medicine. He also is Emeritus Professor at the University of California, Berkeley, and co-directs the Network for Multicultural Research on Health and Healthcare at UCLA. He has published more than 170 articles and chapters, in addition to several books, and is the recipient of several awards and distinctions. The 2006 ISI Web of Science listed him in the top half of 1% of the most highly cited researchers worldwide in social science literature over the past 20 years. So not only is this man brilliant, but he is charming, witty, and a good sport. We had the pleasure of having dinner with him last evening, and while his hotel was within walking distance of where we met, he took a cab, and he got a first-time cab driver. So he's in the back seat with the GPS, helping the cab driver get him, into downtown, out of downtown 5 o'clock traffic and to the restaurant. So that was a good story. He is married and has 3 boys in age 25 to 31. And I like the story that you shared about his oldest saying, "Dad, I'm 31 and I haven't accomplished a thing." And he said back to his son, "You have 70 years. Think about it. It's true." So with that, it is my pleasure to welcome Dr. William Vega. Please join me in welcoming him to Colorado and to our forum today. And the topic he's going to be focusing on is healthcare professionals and an increasing diverse older population, what's needed to align the practice of care. Thank you.
Well, it's really a pleasure to be with you here today in your beautiful state, in this beautiful city. And I really mean that. It's really a beautiful place to be, is Colorado, and it's one of the really nice places to be in this country. I also know that your work is so important, and I know that you need very few lessons and instructions about how to do the work you do. You're so experienced in it, and you're involved in very important endeavors that are quite complementary to each other as I meet more and more people who are here today. I think that's always, our major goal, isn't it, to try and figure out how we can work better together and how we can do a more effective job of bringing the change that we want to bring. Before I begin, I think a good place for me to start would be to just say to you just a couple of words about Ed Roybal. I don't know how many of you even remember who he was, or who, I'm sure those of you that were in my age bracket certainly know who he was. Ed Roybal was a person who was a real pioneer. He was the first Latino congressional representative of Mexican origin that was ever went to the Congress. And he came up in a way that some of the people in this audience will really understand. He was a person who he lived in East LA with his family and was very concerned about the tuberculosis epidemic that was taking place in Los Angeles at the time, and the polio epidemics as well, because Latinos were disproportionately being affected by these things. So he used to go around to the community churches, and he used to go to the movie theater, to the $1 Million in downtown LA, where they were playing all the great movies of the 1950s back in those days, and the Cantinflas movies and all those things. And at the break, where they used to have mariachis in the break between the movies, he would come out and speak to people about the importance of being screened, the importance of taking preventative measures, et cetera, about these issues. And he was not a health-trained person. He had gotten his degree at UCLA in something completely different, but he was very concerned about these issues. He was concerned that the community was not aware of these problems and needed to act. But he was so effective at the podium that ultimately what occurred is people encouraged him and urged him to become a candidate, for city council in L.A. Well, there had never been a city council person that was a Latino in L.A. at that time. This is back in the mid-'50s. I know it's hard to believe for L.A., but L.A. was very different then than it is today. So when Ed was elected and he went to take his place in the chamber with the other council people, the rest of the council people walked out because they didn't want to be seated with a Mexican. This is in an era of straight-up redlining, blacks from one place, Latinos in another place, and they were not going to be moving into social positions or geographic positions where others lived in the community at that time. But he fought through that at a time when he was enduring enormous harassment for himself and for his family and for his children, who were directly threatened. He actually had safe houses set up around the community, so when his children were coming home from school, they had safe houses they could run into if they saw the police. And this is the difficulties that he put up with, and it wasn't much better for him when he went to the Congress. But he fought with absolute fidelity to move these issues across and to make certain that the kind of legislation that went forward was dealing with the issues of inequality in the United States and the health problems of the United States. This is why when you go to CDC, the main campus that's doing all the great work in Ebola in Atlanta, the main campus is the Roybal campus. There are more public buildings, except for other than presidents, named after Roybal than any other person that has served in public life. He did an astonishing job of conquering all that resistance, working around the resistance that was there, the outright racism and everything else that he had to contend for decade after decade, and developing coalitions in the Congress to move forward his agendas around improving health and establishing programs at the CDC and at the NIH, et cetera, that would deal with all these great issues, especially aging. That's why the national research centers on aging are the Roybal centers on aging. So, it's an astonishing record. His daughter still serves in that capacity. 54 years later, Lucille Roybal still serves in that capacity. So that district has been well represented for a long time. But I'm just putting this forward because it just shows when people that really are dedicated, even if they weren't brought up with specific specialty knowledge about an area, but are so concerned about issues and so concerned about communities, they can make enormous processes of change and at so many levels. And when they begin to become aware and understand the necessity for advocacy, the necessity for patience, necessity for coming back from failure and being able to have an effective way forward. So I think all of you know that lesson at various levels, and you've all experienced it at various levels. And I think that's really why we're all here, to sort of recondition each other, give ourselves another charge up, and continue on with the great work that everyone is doing. So today, I'm going to check my clock here because I know that I've got a limited time here. I just want to be sure that I don't run over it. I'm going to actually be speaking to you about issues that have to do with how we think about health and Latinos and the situation that they are facing in the United States today. We know that the issue of health is a complex one, and I'm going to spend a certain amount of time dealing with big ideas about what's going on in the country right now in relationship to Latinos, and also how it comes down to the issue of what you really see every day in your work here in Denver and in Colorado. So, as we move ahead with that, the aims of the presentation are to understand the Affordable Care Act as a rational approach, not a baked cake, a rational approach, because that's what it is. It wasn't something that people thought, oh, we have the final version here and it's going to work perfect. It was a strategy. It's an approach to reform. And it's going to have many mid-course corrections before we ever get to the point where we say, gee, this is really great, and it just accomplished all the things it wanted to do. The scope of the Affordable Care Act assumptions and the implementation strategies are really about improving population health. It's not the prime goal to get people into having access to primary care or something of that sort. It's about improving the health of the nation, reducing the burden of disease. And this has everything to do with people who are, of course, over 60 and beginning to face stages of life in which they'll have more and more unfortunate victimization by disease. So what we're trying to do is really think in terms of how can we make this a healthier nation, and the healthcare piece, a critical piece of that, but not even the most important piece of that. All right, I want to make that absolutely clear. And how do we meet this challenge for aging Latinos and for other vulnerable groups, because there are certainly other vulnerable groups in the country. And we can't make attaining the perfect healthcare system the enemy of establishing a good and workable healthcare system where we improve access to care and quality of care. So I want to make clear one thing, that we talk a lot about disparities in health, and I think that you have to understand that there's really two great arenas in this world when we talk about disparities in health. One has to do with the actual disparities in health because there's excess disease in certain populations. That is one kind of disparity. An entirely different kind of disparity, although it's related, is the question of disparities in health care. That is to say, are people getting equal quality of care when they actually go for care, which is a very different question. You might not have a problem in terms of a disparity of health. For example, Latinos do not have excess death from cancer. They actually have lower cancer rate death. Nevertheless, they get lousy care. They get no care or they get bad care, and in the main. So the question becomes, all right, then how do we improve the latter so that people can live longer? Because the one thing we know is that if you needed the quality access to care situation resolved, it's especially true when you're over 60 years of age and moving on, and when people are going to be living to 70 to 80 and to 90 and going on into 100 years of age, increasingly as we go over the next 20 to 30 years with the great controls that we're getting for self-management of disease and the effectiveness of newer medications. It's going to be a common problem, but the problem is going to be having quality of life that results from all of this. So the bottom line is I'm making the point that this is a 20-year train ride that we're on right now to try and coalesce these various things that we're doing in healthcare, in community work, all along the line here so that we begin to see fusing and focus coming to the work that's going through the circuits of what you heard here this morning right now in building communities, building strength in communities. And of course that means building a solid social component to our citizenship in the society, which means education, social mobility, taking your place in the society, having leadership roles, etc. And it also means, as part of all of that process, that we're going to be able to straighten out many of the complexities of putting together systems that were never designed to work with each other in the society. So it is a great challenge as we move forward. And as I look at aging, I think that the critical issues really are built in stages, and they're quite discrete at this stage in time, and more I think they're going to have some reflection and connection with each other. So that we're really talking about, as we heard this morning, improving communities and their health. As we improve the quality of communities, we will improve the health of those communities. The integration of services, because clearly services in the health side and the medical side, et cetera, are not well coordinated in the past, and they need to be much better coordinated, especially in aging. And then, of course, re-engineering pension systems because they're so woefully inadequate. I mean, the average amount of money given to a person who's worked for 40 years, average Latino or African American in this country is $1,000 a month. Well, I mean, that might work in Alabama, but it does not work in L.A. And in L.A., you can't get one room for $1,000. So, how are you going to live on $1,000? And, we do increasingly have more and more people living alone. 25 to 30% of people over 65 are living alone, including Latinos. Less and less can we depend on the old classic situation of, all the generations will live together like on the rancho in Mexico. That's just not happening, So we have to figure out, all right, how do we develop pension systems that are somehow more equitable than they are right now? Because medical doctors at the medical school who are millionaires when they retire still get high-end payouts on Social Security of $30,000 a year, and others are getting $1,000 a month that have nothing to turn to besides that. So as we move on from discussing, and of course, viable long-term care. Viable long-term care. We all know about that one, and that's an absolutely critical one because we don't have it. We don't have it for people that can't afford to pay for the insurance up front, which is expensive. And we thought we were going to have it in healthcare reform. Remember that? We were going to have that special program that was going to be inset in there. You were only going to pay $50 a month if you were low income, and you were going to have long-term care. But that went away because it could not be an entitlement program. It had to be a program pay-as-you-go, and it just wasn't fiscally viable. So I want to tell you that I did take some time to look at the state of Colorado before I came here to see how similar it was to the situation in California. It's very similar, actually. I was really surprised. You see a population that is approximately 21% of the population. Of course, in California, that is much higher, but the median age is about the same, around 26. The median annual personal earnings, $22,000 a year in today's economy. So we know what that means. We know what it means structurally. We know what it means in terms of opportunities for education, et cetera. And we know that the poverty rate of 31% is a standard across this nation for people under 17 years of age for Mexican origin. That's just the way it is, and it's very similar for African Americans. Without health insurance, about 27%. Actually, I think that is an exceptionally high, let's put it this way, that's exceptionally good performance for the state of Colorado, because in California it's much higher than that even today. It's about 39% right now in California, even with ACA, because we have so many undocumented immigrants in California. Home ownership, 47%, something you see routinely among Latinos as well. Even though they don't have much money, they have homes, and they buy them, even if they're not expensive, but they fix them up and they live in them. This is harder and harder to do in many states because of the cost of property and income and the low salaries, and the systematic inequality that we've been producing since 2004, 2005. And we've come out of this situation with a real problem in adequacy of income. And the percent of all K through 12 students, of course, 1 in 3 or more or less, and that's going to continue to get higher. That'll be 40% quite soon, I'm sure. So here is the actual national data on the median worth of households by race and ethnicity, 1984 to 2011. So you can see what has happened is pretty much stagnated along the bottom. African Americans very similar, and they end up in exactly the same place just about. This is their total net worth here in terms of median net worth assets. 6,004 and 7,800 versus the white population of the United States, $91,405. So you can see what we're talking about. I actually have another one that shows it's slightly better for people that are over 69 because they've accumulated the assets through their home. So these are sort of passive assets because they're in their homes. But you can see it's still different. I mean, African Americans, Latinos have these much higher levels of income over 69 than they do earlier in life, but it's still far different than what whites have. And the whites also have the situation where through the earlier years, 49 to 68, they also had high income, so which means obviously they're in a much better situation in terms of having a home that's more likely to be paid for or close to it, or assets and investments, et cetera. So there's quite a different situation going forward to the silver years, all right, when you go in and you're vulnerable, you're feeling vulnerable, and you're wondering how you're going to handle any of the great emergencies that you can anticipate coming in your life. So we know that much of the problem in the past has been rooted around the issues around residential segregation and racism, institutional racism, problems that we're trying to work ourselves through, whether it's through the courts or through other means. The Affordable Care Act is attempting to overcome many of the disparities that have come forward in the health area. But we know that these situations continue to persist, and they're really difficult ingrained problems at the root of everything that we're talking about, because such things, for example, as segregation and redlining mean that people end up in districts in which the school districts are vastly inferior. We have very high school dropout rates, non-completion rates. And really, the education is poor to the point where in grammar school already, in elementary school, they're already doing badly enough that they have very little hope of doing well as you get to the more complex subject matter in middle school, and then they're completely out of it by the time they get to high school, and we have these high dropout rates, the non-completion rates. We have to get past that problem. If you look at the structure of America with increasing Latino and African American Asian population, they're going to take over America past mid-century in terms of driving the future of the country. You have to have people who are going to be well educated and replace the income, the revenue streams that have been there traditionally from other populations that are now retiring. So who's going to replace those populations? Who's going to be able to supply that makeup in the income? Well, well-educated people have to do it, and they need to come forward. They are coming forward, but just not fast enough. I mean, in California, the majority of people in the California State University system that are applying for and actually getting in, not the University of California system, but the California State University, San Diego State, San Francisco State, those schools, are Latino names, not surnames. And good, because they reflect that. But in the UC system, very little. I mean, it's really hard to see any representation of Latinos and African Americans in the UC system, in leadership roles, and in medical schools, and in university professor roles. It's just not there, not even now, with this massive population that we have. So, it's a long way to go there. At the same time as I say that, the good news is, and this is just data from LA, to give you, it's very similar to the national data, and I'm sure what you'd find in Colorado as well, that actually is a very good story to tell, because over the decade from 1999 to 2009, we've seen decreases in mortality from all these major killers. Coronary heart disease death has gone down by 42%, stroke by 41%, lung cancer by 23%. Down here, colorectal cancer, liver disease, all of these have done well. Homicide down by 33%, HIV/AIDS death down by 50%. So we've made progress across all the populations. It's just that the disparities in the areas in which there are differences it's sustained. For example, in diabetes, there's excess mortality for diabetes among Latinos. It has sustained, even though we've had an overall decrease. So what's happened is everyone has done better managed, including the chronic diseases are better managed, but the outcomes are still not so good. So, but the bottom line is, as you get this, you also get this. That's not a 94% decrease. That's an increase. So what we have is people living longer, but they're living longer with dementias, with Alzheimer's specifically, and of course we have a whole bunch of other problems associated with these later stages with management of diabetes, heart disease, et cetera. So, this is a complex picture, and it does mean that we have a burden coming forward that needs to be better managed holistically, organically from the community level forward, better self-managed within families, because there's no way that the medical system can ever take care of this. The shortage of doctors, the shortage of capability financially to deal with a situation that's totally put on the medical system, it's simply unworkable. So we simply have to regenerate society and regenerate our communities. Now, we've done a number of studies in my group and other groups as well around the issue of what happens in older age. And what we see with Latinos is fascinating because they live longer than whites do in the United States, actually. I mean, they have better health. That's that paradox phenomenon that they actually live longer. Most of that is attributable to lower smoking, by the way. People wonder, where does it come from? Well, smoking in Mexico among women is very low, almost non-existent, and it's very low among men, too. So what happens when they come to this society and over the years that they've never really picked it up to the same level. So that has an enormous beneficial effect in lowering cancer rates, COPD rates, and cardiovascular risk rates. So they actually, even though cardiovascular is still the major killer in all groups, it's less likely to be as high in Latino groups because of the fact that they don't smoke. So you get a beneficial effect. People live longer, but the accumulation of all of those years in poverty, difficult occupational situations, et cetera, ends up having a cost at the end of a lot of disability and a lot of multiple illnesses that have to be managed somehow by somebody. And in many instances, it's by people who are in this audience right now that have done this and are doing this right now, helping loved ones manage these conditions. So the fascinating thing is when you look at the expert opinion, and believe me, this is some of the best, I think, people who have ever thought about this issue, of attributing the importance of different determinants in society to what produces health. You look at 4 basic sectors. One has to do with our behaviors, because we know our behavior produces good and bad health, how we eat, if we exercise, the issues around how much alcohol do we use and drug use, et cetera, all of these things. These behaviors are voluntary behaviors that we get ourselves into, and we do them or we don't do them. Those are important determinants. Clinical care, of course, medical care is important. Social, economic factors are important. Physical environment. So these are the 4 great domains that they're looking at that we think need to be modified through public policy, through health policy, social policies of various kinds. But the fascinating thing is, look at the contribution levels that they give to each of these. About clinical care, medical care, they believe is responsible. This is at the national level. About 20% of all health is produced from medicine. Immunizations, self-management of chronic disease through medical guidance. But 40% of it is produced through social and economic factors. In other words, inequality is producing a big part of the health problem. And the issue of producing better health has much to do with getting better educations, better income, and producing better communities in the process. Health behaviors is seen to be about 30% of that, and it's of course influenced by the socioeconomic factors as well. These are obviously related. And the physical environment is seen as about 10%. In other words, the toxicity of the environment you're actually living in, and how well that environment really supports health. So the bottom line is that even though the Affordable Care Act is important, nobody in Washington who produced the Affordable Care Act ever believed that better health care was going to produce better health in America as an overwhelming effect. It had to come as a stage of coordinating other elements in the society and all the way to the community level. And that's why a lot of the effort has gone under affordable care to CDC, to the Center for Disease Control, to put money out to communities in order to better the possibilities of addressing at the community level issues around food supply and its quality, to the suppression of tobacco use, and all these other issues that are associated with basic community health. So the efforts now are really very holistic in trying to understand how the pieces fit together. So the roles that many of you are engaged in right now are right down that alley. That's exactly what many of you are doing, and I think it's exactly where we have to go with what's going on now. Now the connectedness between the pieces is where these are all arenas that are difficult because we're dealing with a situation as I say here, how much can we improve health and healthcare without a corresponding increase in income and education? Because in the short haul, in the Latino community, we are not going to make an astronomical leap over the next 20 years in the education and college completion rates in this community. We're going to make an increment, but we have this influx of the immigrant population with very low education levels is going to be very stagnant. Their intergenerational change is going to be very low at this point because there are no mechanisms to move that group forward. What we have right now is the second and third generation that have more assets in the Latino population, and they are getting educated, and we're seeing that. So it is an intergenerational process. Speaking of generations, is 20 years. So as I see it, right now for the time being, we're operating against the current for a spectrum of our population that is the least advantaged. And we have to think in terms of setting targets for how to show improvements. Given that set of disadvantages, how do we set targets to see that health status issue move up? Because we know it can be done to a certain extent. We can't create a situation of overcoming completely the differences in economic inequality and the impact that has on health. But we can do a lot of things to improve the quality of health and give people more opportunity for a good life. How do we design and implement social care support systems in the case of elderly people to reduce the need for health care by preventing treatable problems and controlling these chronic conditions? That's really the main charge right now. So aging in place, we all know people want to live in their own homes. They don't want to be put in an institution. We know that they need to have certain basics. They need to have a home that you can live in that's safe. We need to have streets you can walk on without falling over them. Like in L.A., I go for a walk, and this isn't a nice neighborhood. If it's dark, you're going to fall over because the streets are all uneven and so are the sidewalks. So I see people flipping over all the time in my neighborhood, and you wonder, why don't they fix, how the roots lift up all the sidewalks? And the city doesn't have the money to go put all new sidewalks and tear out all those roots. So you just got to keep falling over, or pay attention, And the whole issue, even getting across the street, on Wilshire Boulevard in Los Angeles, you got 20 seconds to get across that street. I see people take 2 changes of light to get across the street. And I'm just holding my breath that somebody's going to run them over. There's such anxiety. That's, 20 seconds in L.A. to have to wait for somebody to cross the street is like a year for any normal person outside of L.A. It's like the most anxious, crazy, thing that you've ever seen in your life. So, current practices in human services and public health have not produced a situation where people who are aging and disabled can really live comfortably in their low-income situation. So we have to think in terms of how are we going to produce that kind of surrounding, sustainment, of resources that can be provided economically. It really, as much as possible, comes from organic sources in communities themselves. So the difficulty really is coming in organizing these 3 great worlds: the community context where we live and where we work, social support, families, health, medical, and social services, and putting these together in different combinations that really work to improve the conditions of our population. So the ultimate challenge will be to functionally integrate these levels and establish these initiatives that foster community and resident participation and advocacy. So I think that you're all involved in that, so I don't have to tell you too much about that. I think you have a good sense of that issue. So the bottom line is I think that community participation is going to be needed, and it's being pushed hard now by health agencies, but we're not quite to the point where we actually have an active model of knowing how to do it, because the transformation under affordable care has come so recently that we're not really there yet. And we're still operating, trying to figure out, how will all these big organizations like healthcare organizations, the privates and not-for-profits, how are they going to engage the community? How are they going to help in self-management? How are they going to help in home assistance? They have the responsibility to do it, to a certain extent at least. And so the question of how they can do it in a way that they've never tried before. And the public agencies, how can they come into communities and do the most effective job when they have always operated on the basis of reimbursement for developing only clinical care programs, not for going to the basic social determinants of inequalities in health? And now they're trying to do it. They're trying to figure out, how do we go about doing that? Where do we touch the community and try to operate some mechanisms or engage with community partners and do this in a way that will make sense? This is the exciting creative opportunity that's before all of you, I think, at this point. Now, we know our communities, this is East LA. Look at the freeways strangling East LA, okay? And they've got playgrounds and schools and everything right next to all this toxic nightmare that's going on. And this is all of the trucks that come through from the port of Los Angeles that are coming to the to the western part of the United States for distribution, stuff from China, of course. it all comes through here, all that particulate matter just floating into these communities, you know, the high toxicity. They should never have built any of that stuff to all these playgrounds next to the freeway, but they did it. And of course, those freeways cut off, as happens here in Denver as well, cuts off the community from the downtown complex and, of course, the rest of LA. So, you know, sort of shunted off, you know, to one side, and it creates that barrier that has always kept East LA as sort of a world unto itself. It's 97% Latino in East LA. So, one of the great opportunities is here through the community transformation grants I told you about earlier from CDC, that is trying to push money into our communities through public health agencies to deal with these core issues. That's a very important push, and I feel terrible that they've left universities out of this. You know, in some ways, I think I understand why. They figure, well, you got NIH, you can do your research over there. But these are being done very quickly, and quite often without the benefit of the ability to evaluate them appropriately or to do research on them to determine what's their impact on current public policy and health policy in the country. We really need to have that linkage, because I don't want to see a return of you know, what we had in the back in the war on poverty days, when we had a lot of money pushed out, a lot of programs took place, no record was done, no evaluation was done. We don't even know what worked and what didn't work. We can't have that again. We can't afford to have that again. We need to use this to bring the ACA, the whole transformation of these communities through better health, to be organically done and clearly learn from our lessons when they fail and learn from our lessons when they succeed. And we also need to, I think this is very clear, that across the nation, people are more and more using assessment tools, simple assessment tools, to identify indicators for your community and then look at them like report cards. Look at the Latino community. What are the issues that need to be rectified? How are you doing over a 10-year period to change those things? Simple tools that go to policy, that go to program people and say, look, this is what's going on. You have not made progress here. You've made good progress over here. So let's shift the burden to something else. So we'll learn tremendous lessons by simply being aware and taking quantitative metrics on things that we are changing and not changing, and looking at hardcore measures of access to care, at health itself in different ways, whether it's youth or whether it's people who are adults or whether it's aging people, because after all, the youth will become adults and will become aging people, and they will ultimately be the final point of all those previous experiences across the life course. Now, Donald Berwick is I believe, the best probably health services person in the country, researcher, policy person. He was one of the people who designed some of the early stages of the Affordable Care Act, not the way he would have wanted it, but the way at least he was part of that process. He had this wonderful statement that I always use when I talk about these kinds of issues. Every system is perfectly designed to achieve exactly the results it gets. So I know all of you have worked in systems, and you know exactly what he's talking about. You know, everyone has a hand in the pie of any particular place. So in Denver and in Colorado versus Texas versus Alabama versus California, there's going to be a very different version of what comes forward as the process 20 years from now of what the Affordable Care Act came out to be, how it was able to move forward and actually deal with the issues, the complexity of uniting these various sectors together for a common purpose. And I think to that end, you know, when you look at a kind of framework for understanding this in the arena of healthcare, clinical care, and community-based care that goes from clinic to home, these are the kind of levels that we have to be concerned about. And I think that on the side of uniting social services with medical care services, we have to think in terms of, okay, what are the critical health issues in our communities? What are the subsections of the vulnerable populations that need to be more carefully addressed? What are the measures that we need to look at over time, just like I just mentioned? And what are some of the facts that make our community unique? And then understanding, you know, what does this really mean? You know, from the standpoint of populations that have, for example, the Latino population, many of them have never made it into care. We have a huge portion of the population that has never had a regular provider, a regular health provider. We have a huge portion of the population that's never had preventive care. Now they're showing up, you know, with the Affordable Care Act is showing up for the first time. Well, they've got a lot of issues that they're going to have attended to very quickly. So the question of understanding the individual patient needs and how to, in fact, improve the quality of the clinical encounter so that people understand what's going on in the clinic. They can find the next stage in their care when they're referred someplace else. They can understand the instructions from a physician. They can understand, and the patients can, the healthcare system itself can understand, and the physician can understand that they can't afford that medication. So how are they supposed to do that? You can't ask them to do impossible things. and screen them out, right from the front end. And so you go through these processes of beginning to learn the populations and the new ones that are coming in, and learn how to work them more effectively, for example, with the language breakdowns and the problems associated with just basic understanding of information. And of course, ultimately on to intervening in the process to change those processes of care. So I want to move this on because I know I'm basically just about out of time here. So I'm going to move it to, this is a bunch of very dense things I'm not going to do because I don't have time to do them. So but I'm going to go back to this one here. Let's see, not that one. Yeah, this one. How do we get there? Clarifying national aims for improvement, changing the care itself, changing the organizations that deliver care, and changing the environment that affects organizational and professional behavior. All of this has to be done. This is the charge in the healthcare system. And I think they're taking it fairly seriously. The difficulty comes in accountability, because we're talking about systems that have never been used to dealing with the mandate of really being responsible for the results of their care. They just gave, physicians give you care, and in the past, you kept paying for your care. And if you didn't get better, you paid for more care. And you went to another doctor and got more care. Now, you have to be responsible for producing results. And difficulties of barriers in cultural differences in language, et cetera, are producing systematically, we know very well, bad results. The national report shows 75% of the indicators that they use for Latinos and quality of care are negative ones. It's worse than any other group. 75% negatives on the indicators that they use for standard assessment of quality of care. Those have to be changed fundamentally and basically. And we still have 41 million people right now who are not insured. Despite the ACA first stage involvement, of course, it's only been going for a little while, but we still got 41 million people. And of course, the most affected population are Latinos because there's such an undocumented group in there that does not have access. They can't get it. So what are we going to do about all of that? That's still there as a residual unsolved problem of access and an unsolved problem of quality. So, it's not going to go away. It's not that they're all going to end up they're not going to end up at the emergency room. We know that. We've done studies nationally on this, even though despite all the negative publicity, Latinos are not ending up in emergency care for their care. They don't overuse it. In fact, they, compared to national averages, actually underuse it slightly. But it does mean that they're going to have to go to health, these gigantic health, in LA we hold one at the sports arena, these big health fairs. 10,000 people come in to these health fairs. The thing that they want the most, guess what? Dental care, right? The level of lost teeth among 50-year-old Latino immigrants in this country is shocking. And we have always played the game that your mouth and your teeth have nothing to do with your health. They have everything to do with it. And they have everything to do with your self-esteem and your ability to enjoy a social life and social experiences and get employment. I mean, it's crazy that we've always segmented teeth out as if they didn't count. So, for me, I mean, it really is a telling tale when you see the sports arena photographs and you see the place full, people going with occupational injuries and everything else, they can only be seen for one day there. But right in the middle are all of the dental chairs, and that's the busiest action is right there. Right there, and also vision stuff. Those are the two big ones. So we still have this residually. And we don't want to see this in children. We don't want to see, and of course, it's least likely in children because they tend to be covered. But still, the question of getting families healthy, keeping intergenerational family healthy, where we're going to see aging people increasingly having to live in these multifamily situations when they don't have any resources. It's the place of the last resort. So we know that we really want to have healthy families, healthy practices, et cetera, and a healthy community for people to have intellectual stimulation, social stimulation, recreation, the ability to have transportation accessible. These things are the basics that everyone in the community will benefit from, and ultimately health will be vastly improved. So despite the great challenges of inequality, which are not going to be easy ones to overcome, and that's a whole other policy discussion, we, I think, can do many, many things to improve the quality of life for low-income Latinos in the country, and especially for those who are aging who need, this kind of improvement in their situation the most right now. And I have to say that overall, I mean, Latinos do live long. They are fairly long-lived. surprisingly, given the ordeals that they have been through in their lives quite often, but they live with an enormous amount of burden. And that burden is passed on to their adult children who must contend with it. So it's not a fair situation, but it's life. And I think we can do a lot from the standpoint of increasing opportunities for everyone to live well and to be able to give a much better chance for people to have those longer extending lives up to 85 and 90 years of age as a routine practice, even in the circumstances of low-income communities, if we deal appropriately with the conditions in those communities. So I'll stop there because we're going to have a conversation about these types of issues, but I certainly welcome any questions that you have later on.
Thank you very much.
Thank you. My pleasure.
Is this on? No. Hello? Okay, we are going to take a 10-minute break so that we can mic up our panelist. Just 10 minutes so that we can have more discussion. Also, we will be making this PowerPoint available, and actually we are recording this as well. So this will be available on our website probably next week so that you can access that as well. So we will have that. And when we come back, we're going to be having the expert panel, and we will be having Senator Dr. Irene Aguilar, who will be moderating that session for us. So 10-minute break.